Hey, good evening, everyone. Welcome to the fourth in our Craniosynostosis webinar series, which is our grand round session, as you can see here. Just a few announcements before we go ahead and get started. We want to make sure that everyone's aware that our Women in Neurosurgery Weekend webinar is happening this weekend, Saturday, February 25th, starting at 10 a.m. Eastern. We have a great series of panels lined up for that, so we highly recommend you register and attend. Additionally, we are going live tomorrow, talking about mind games at 7 p.m. Eastern, and then again on the 23rd, also at 7 p.m. Eastern, doing our neurosurgery program spotlight. On New Mexico University School of Medicine, specifically their residency program. The neurosurgery journey also goes live every Thursday at 7 p.m. Eastern, so definitely check that out. And we have our fundraiser ongoing for a brain injury to serve military veterans and patients that have suffered from brain and spine injuries. And lastly, all of our videos can be found on our video library, both through our website and on YouTube, to check out any of these after the fact. So if there's any in the series that you missed that you want to go back and review, we highly recommend you do that. And lastly, without further ado, I would like to introduce Dr. Mark Proctor, who is giving our grand round session tonight. Mark Proctor is the neurosurgeon-in-chief at Boston Children's Hospital, as well as the Frank D. Ingraham Professor of Neurosurgery at Harvard Medical School. Dr. Proctor obtained his undergraduate degree at Dartmouth and his medical degree at Vagelos College of Physicians and Surgeons at Columbia. He went on to train in neurosurgery residency at Georgetown, followed by fellowship at Boston Children's Hospital, where he has been on staff since 1997. He is the director of the Brain Injury Center at Boston Children's Hospital and nationally has been incredibly involved in advocacy and injury prevention. He is the immediate past chairman of the pediatric section of the American Association of Neurological Surgeons and the Congress of Neurological Surgeons, and is past president of the New England Neurosurgical Society. Dr. Proctor has particular interest in minimally invasive treatment of craniosynostosis, and he is one of the world's leaders in performing this operation and has studied the long-term effectiveness of minimally invasive craniosynostosis treatment. So without further ado, I'm going to stop sharing my screen so that Dr. Proctor can share his.
Great. Let me just get that going here. All right. I assume you're able to see the screen now?
I can, but you just go into the full screen presenter mode. Perfect. That looks great. Thank you.
Great. So just speak up if there's any issues because I can't see you now, but thanks for the invitation to speak. And unfortunately, I missed the other talks in the session, so hopefully this won't be too repetitive. As mentioned, my real contribution is on the minimally invasive endoscopic treatment of synostosis. So I'm going to sort of weigh that against open treatments, but I'll start with a little bit of a review of what cranial synostosis is. So nothing to disclose here. So I'll start with some very basic embryology and things you may or may not recall from your embryology classes in medical school. But as you look at the skull, it's unlike the other bones in the body. It's a very specific way of bone growing. It's called membranous bone formation. So most bones in the body form by endochondral bone formation, and that includes the bones at the base of the skull below this little line here called the mendosal suture. But all of the major cranial plates are this membranous bone formation. So you start early in gestation on the left here with these little patches of bone that then keep growing and come together. And the little interfaces are called the sutures. So you have the lambdoid suture in the back, coronal suture on the sides, and then other sutures you'll only see from other views, which is the sagittal suture over the top and the metopic suture in the front. Okay, so it's pertinent to go over a little bit of the anatomy to understand how head shapes can be affected. So what are cranial sutures themselves? They're very cellular, and they're what we call osteoblastic. So I always think of the B in blastic for building. So it means osteoblastic means you're making new bone. So these sutures make new bone very quickly. They're very cellular and they're highly influenced by biomechanical forces. So as the brain is growing and pushing the bones apart, the sutures are growing new bone, like almost at exactly the same rate as the brain is growing. Eventually, that should start to slow down, right? The growth of the brain is vastly complete even by the time you're born, so that you're supposed to slow down. But if it doesn't slow down and you get excessive growth of bone, then that's when you get this synostosis, or the premature fusion of the bones. So what exactly is synostosis? As I said, it's congenital, meaning you're born with it. It's characterized by closure of either one of those sutures, and there's sort of 6 major ones, or more than one of them. And each time a suture closes, it results in sort of a stereotypic abnormality of the head shape. So when we think about synostosis, most cases are what we call sporadic, meaning no one else in the family had it. But there's also what we call syndromes, like things like Apert syndrome and Cruzon syndrome. And I operated on one of each of those today. And those are much rarer. So overall, you see craniosynostosis about 1 in every 2,000 live births. But the syndromes are about 1 in every 30,000. And just so you're familiar with the term, secondary synostosis it's a very different phenomenon. That's what happens if the brain isn't growing. So think things like Zika virus or a neonatal stroke. The brain's not growing, not pushing the bones apart, so the bones fuse together simply because nothing's pushing them apart. So when we think about synostosis, I don't want to say there are no animal models, but there are relatively few animal models. So why is it such a uniquely human disease? And there's 2 predominant reasons. One is we have a large brain, right? So we have a lot more growth to account for in our brains than other animals. And the other is that we walk on 2 legs. So why does that matter? Well, if you think about the weight of a baby cow or an elephant or anything that walks on 4 legs, all of that weight is on the abdominal wall. So as the mother is walking around, the weight of the fetus is on the abdominal wall, and the abdominal wall is pretty strong. But in humans, because we're walking on 2 legs, as we walk around, the weight of the fetus is on the pelvic outlet. And as such, we simply cannot hold a pregnancy until we have full brain maturity. So if you think about a little calf being born, it can actually get up and walk away from its mom within a very short period of time, minutes to a couple of hours, whereas humans can't do that, right? It's about a year before they can get up and walk away from their mom. So there's a whole lot of social implications in that, right? It's why we form family units and tend to have separated off into couples, because you have to care for the young in ways that other mammals don't have to. But it's also why synostosis is a problem, because most other animals are born with a full-size brain, and humans don't really achieve that full-size brain till about 1 to 2 years of life. And even then, it's not a full-size brain, but it's substantially complete by 2 years of life, about 90 to 95% complete. All right. So if you think about normal growth of a skull, think of it like a balloon inflating. Each day the brain's growing a little bit, and it's pushing each of the bones apart a little bit. So if you have the sagittal suture here and the brain growth is pushing those bones out medial-lateral, so out to the sides, if that sagittal suture closes, well, you can't grow as much out to the side, so you grow more in length. And that's called Virchow's law. And basically it says skull growth is restricted in a plane perpendicular to a suture, premature future, and enhanced in a plane parallel to it. Okay, so we'll hopefully get through most of the background here soon, but if you want to just think then, how does the skull grow? Well, here's the normal skull on the left. And then for each of the various sutures that can close, you can see the deformity that results. So we're just talking about sagittal synostosis, which is a long, narrow skull. Well, what happens if this left coronal suture closes? You get flat in the left frontal area. Your ear pushes, well, it doesn't really push back. It stays forward because it doesn't get pushed back. So you're flat and the ear stays forward. Classic sort of deformity. Don't need an X-ray to prove it. Don't need a CT to prove it. It just physical exam should be enough. Lambdoid synostosis, you get flat in the back, and again, the ear stays back because it didn't get pushed forward. And metopic synostosis is one of the more varied ones, and we'll go over that. Okay, so what do you have to distinguish synostosis from when you see a little baby with a head shape abnormality? It's this. It's deformational plagiocephaly. It's a baby who's been lying in a certain way, and because their heads are a little heavy and soft, they can get it flattened out. This really took off in 1992 with the Back to Sleep program. Probably most people listening to this were subject to the Back to Sleep program. So if at this point, if you're under about 30 years of age, you were probably sleeping on your back as an infant because it reduced the rate of sudden infant death syndrome. But it also has led to this sort of epidemic of flatheads. Really a cosmetic issue more than anything else, but something we probably see 30 patients a week for in our department. Okay, so now that we've gone through what it is and how to diagnose this, let's go through a little bit more of the basics. So how do we assess the shape? I'd say in general, I almost never get x-rays or a CT scan, at least not to make the diagnosis. Why is that? Because once you understand the deformity, you should be able to make the diagnosis just by examining the child. So I think of imaging as an adjunct to surgical treatment, not a diagnostic tool. So here are just some x-rays. If you look at the one in the middle and on the right, this is classic sagittal synostosis, so a long, narrow skull. And here you can see that premature effusion up over the top. But I could have made this diagnosis just as easily on the patient. I didn't really need the x-ray to do that. The view on the left here, this is what we'll call right unilateral coronal synostosis. So this right suture is fused here. And this is a very interesting phenomenon called the harlequin eye sign. So this little peak off the eye, someone thought looked like a French clown, called the harlequin eye. So like I said, any of these diagnoses that you're making on x-ray, you should be able to make on the patient. Do we ever get anything more than an x-ray? Well, sure. So sometimes it's really important to get films, right? So this is a deformity called a cloverleaf skull, and no surprise as to why it's called that. It's just shaped like a clover leaf. You could see all the skull bones being eroded here. So this is fusion of every cranial suture. And when that happens, the brain starts struggling for room, and it starts eroding the bone. So that's a cloverleaf skull. And it's important to have a CT because you want to understand exactly where the fusions are, and you want to understand the nature of the brain. Scans can also be very helpful for following children over time, right? So this is a child with Apert syndrome. They have bilateral coronal synostosis. So if you look on the left here, the coronal sutures are closed. This is after I'd done an endoscopic release. So I opened the suture, used the helmet, and the head is now lengthened out. And the height of the head, which had been growing too high, started to correct as well. Okay, so now we'll really focus on the surgical treatment of synostosis, and again, get into the nuances of when do you do a big operation and when do you do a small operation. So there's been a real cycle in the treatment of cranial synostosis surgery. If you sort of look to the top right here, in the 1950s, that's when we really first systematically started to treat synostosis. There was some treatment around the turn of the 19th century into the 20th century. Basically, all the kids that got operated on at that point in time died. So for about another 50 or 60 years, there was no surgery for synostosis. But then in the 50s, as surgical techniques started to improve, the operation became more popular. And most of the early operations were big incisions, ear-to-ear incisions, or front-to-back incisions. You do that, you'd move the bones out in various ways. So there's all sorts of different things. I'll show you some of them. And what was found is that, gee, it's a big operation and the results weren't great, right? So in doing these big operations, you didn't always get great results. So people started thinking, well, maybe we should be doing smaller operations. And even though smaller operations didn't always work in the past, maybe there were some new things that would help. So the current era of what we call minimally invasive surgery is doing small incisions, taking out the fused bones, and then using adjuvant therapies like a helmet or springs to correct the shape. So we've really sort of come full circle from these what we call strip operations in the 1950s, got away from them because too often the bones fuse back together, and now we're back to strip operations, but we're doing them in a different way. Okay, so if you're a student that's at a modern craniofacial center and you have a newborn that has synostosis, basically what you're probably going to see is that baby's going to be referred to a multidisciplinary team, and then based on the age and what type of deformity is, et cetera, they're either going to go down the route of an open cranial vault procedure or a minimally invasive procedure. So there's an interesting phenomenon that goes on in this field, is that endoscopic surgeries now has been around for about 27, 28 years. It's actually been shown to be quite effective. There's been more articles on endoscopic surgery than on open surgery. And yet we're a little bit slow to adopt it. So, I'd be considered one of the leaders in minimally invasive surgery, but there's a lot of centers that don't do it. Don't do it at all, don't do it very extensively. And the question is why? And I like to use this parallel of looking at laparoscopic cholecystectomy. So for many of you, as you go through your general surgery rotations, you may only see a laparoscopic cholecystectomy. But in the past, they never had laparoscopic cholecystectomy. It wasn't until the 1987 was the first report, but it was really around the late 1980s that it became popular. And it was first met with very significant skepticism. And I think some of these early articles they're just a little humorous, right? So laparoscopic cholecystectomy, passing fancy or legitimate treatment option. These were all articles from right around 1990. Laparoscopic cholecystectomy, let us control the virus. And, it's a pretty damning way to refer to the operation. Laparoscopic cholecystectomy, fantastic, ? So clearly the general surgery population was not adapting this type of surgery very quickly. But then really just within a year or two of that, then we have laparoscopic cholecystectomy, evolution, not revolution. People trying to finally accept that these are advanced techniques, not some barbaric way of doing the operation. And then laparoscopic cholecystectomy, threat or opportunity. So, within, again, just a couple of years, it was made clear laparoscopic cholecystectomy was there to stay. And general surgeons really had to understand how to use that operation. And one of the real things that came out, and this is from that last article, is only surgeons involved with open cholecystectomy and management of its potential complications should perform the procedure. And I think it's very analogous to synostosis. If you don't know how to do an open operation, if you don't fully understand the skull, you can't do these minimally invasive operations. But if you understand it well, then you should be able to do either one. So, this is an article I published now over 10 years ago, endoscopic cranial suture release for the treatment of synostosis. Is it the future? And I think the future is now. I mean, I think if you're treating this condition and you're not able to do endoscopic operations, you're really not doing a great service for the patient. And this is also a task force that I was the lead neurosurgeon on back about 11 years ago, sponsored by the CDC. And basically what we came out saying is that these multidisciplinary teams are really important. Endoscopic treatment is a great option, and you just have to understand how to do them all. Okay, so now we'll just really focus on surgery for the rest of it. So I would say that if we look at the two types of surgery, you've got your open surgeries. These are purely mechanical operations where you're taking off the bones and you're reconstructing them, and it's sort of like erector set type things. You're really rebuilding the skull. And the endoscopic surgeries they're philosophically very different. You're not taking apart the skull. You're just restoring the anatomy to the way it was meant to be. You're taking out the fused sutures and hoping that things are going to grow normally over time. But you're doing that by using some sort of device like a helmet or springs to correct it. And where I put here, conceptually, you're turning synostosis into a deformational problem. For all those little babies that have flatness in the back of their heads from the way they're sleeping, we started using helmets to correct them, right? So this is essentially the same thing. You're turning synostosis into a deformational problem because you're taking out the fusion, you're making the skull bone soft again, and now you're using the helmet to reshape it. So if we look at a condition now like sagittal synostosis, here you have that long, narrow head. In this case, the baby is positioned with the head down towards the bottom of the screen. There's the endotracheal tube, marking out incisions, marking out the various sutures. What are we dealing with? We're dealing with a long, narrow head, right? So here's the actual baby with synostosis next to his CT scans. And here you can see the pretty classic findings. Sagittal suture is closed. The head is bossed out in the front, meaning the forehead's a little overgrown. They're bullet shaped in the back, very narrow, and they have that dense ridge. And the other thing, as you get better at this, you'll realize that the head, normally the highest part of the head should be the very top. And with synostosis, you have this downsloping. So the highest part of the head is the front, whereas it should have been over here. It should have been the vertex of the head. All right, so if we have a child like this, what are we trying to achieve? We're trying to lift the back of the head with our correction. We're trying to widen the back of the head. And as we look at them from the front, we're trying to sort of bring down the peak of the head and make the parietal area here the widest part of the head. Okay, and I would argue that if you look at the bottom right here, what's labeled F, you're trying to get from this shape to this shape, right? You're trying to get it wider and smoothed out on the back. And there's lots of ways you can get there. You can do this. In this case, the yellow represents the incision. So you can make these two small incisions and remove the bone and then use a helmet. You can make the two small incisions, put in springs. So now you don't need a helmet because you're physically pushing the bones apart. Or you can start to do all sorts of variations of big operations. So here you're opening the scalp completely and you're making various cuts. Sometimes we use what's called distractors. These are little pins you go in, and each day the family takes a screwdriver and turns the pin because the pin comes out through the scalp. Or we could do just big reconstruction operations, right? And I think it's fair to say, well, if our goal is to get from one shape to another, isn't it best for the baby to do it in a way that's most physiologic, the least bleeding, the shortest hospital stay, et cetera, et cetera? So now I'll take you through just a simple case of sagittal synostosis. This is the specialized head holder we use for sagittal synostosis. Here we have the baby positioned, injecting local anesthesia, making our incisions, use something called a Colorado needle to open it in an essentially bloodless fashion. Then we're going to get down to the bone here. And we're, doing everything front and back because this is sagittal synostosis, so we have to release that whole long suture. We use a high-speed drill to make our first burr hole, and then we're going to start to open up the bone. And obviously this is sped up, but the whole operation is only about 20 to 30 minutes. So once we get that going, we're going to bring in the endoscope. And you'll see that starting right about here. So that's the endoscope going in. And next I'll show you the view from the endoscope. So here's the bone work we started to do. And now we're going to use the endoscope to push down the dura. You can see that dense spike of bone from the fusion there. That little V shape over here. So we're just separating the dura off of the undersurface of the bone. And there's the burr hole up front. So we've already connected front to back. I think we'll take one more little look under the bone here. And once that's all done, it's just, the brain is safe because you push it away. And we just use a heavy scissor to cut out the strip of bone. And once those cuts are made, you'll see us taking out the bone. I think in this video it comes out in two pieces. So there's one from the back, and here it is coming from the front. But we've essentially just cut out that fused portion of the bone. Put in some gel foam to allow for hemostasis. And then close up the incisions. Pretty straightforward operation. And again, it takes about 20 to 30 minutes. The rate of blood transfusion should be well under 5%. And again, here you can see a child before and after surgery. These are laser scans. These are the scans that are used to make the helmets. So they're actually very accurate. So they're 3D CAD CAM systems that scan the entire head, then a mold is made of the head and the helmet is made to fit the mold. But you can see the nice correction over time. So let's compare that to some of our bigger operations, right? So what we call caveral vault remodeling operations. And this is just one method of doing it. It's called the Melbourne method. The plastic surgeon I work with, John Mura, came from Australia. So he likes using the Melbourne method, but you can see it's fairly complicated, right? So first you have to expose the entire skull, and then you label all the different parts because you're moving them around every which way. And here you can see it in the flesh, so to speak, right? So this is that Melbourne method. So we expose the entire skull, we draw out this template, we label everything because once you take it off, you got to know where to put it back. Then I make all the cuts using a high-speed drill. All the bone is removed, right? So you take it off, then the plastic surgeon's working with it on a side table and starts putting them all back in this very sort of meticulous, structured way. And here you can see as we're getting near the end of everything going back. And here it is at the end, right? So we started with a long, narrow head, and now it's been widened out substantially in the back. It's been shortened a little bit, and it gives a good correction, but it takes a lot longer. Baby needs a blood transfusion. We'll spend a day or two in the ICU and probably about 4 to 5 days in the hospital. But here you can see the correction. It's a pretty good shape correction, right? So that's the same baby before and after, and you can see skull's been widened out and shortened and also lifted. You see how I mentioned how they downslope, and now they look pretty good. So they're both really good operations. It's just one is a much bigger procedure. And we'll go over how we make the determination of which one to use. Coronal synostosis. So we went over that a little bit in the x-ray. So this is when one of the sutures in the front closes here. And what happens when that occurs? Well, you get closure of the suture. So here's a right coronal synostosis. The eyes always become asymmetric. So the eye on the affected side is much higher, but it's also flatter. So it almost looks like the eye is popping out of the head a little bit, what we call exorbitism. And the nose always tilts over to that affected side. So it's a pretty classic diagnosis based on appearance. So again, how do you correct it? Well, you could do what's labeled B here, where you make a small incision and you just take out that fused part of the bone and then use a helmet. Or you can do a bigger operation where you make that ear-to-ear incision and you take off all the bones and move them into the right place. And again, I'd say if they're both going to work equally well, you might want to think about the one that's least invasive and least traumatic to the child. And these are just further examples of helmet therapy. So you see before surgery on the left, during therapy in the middle, and after therapy on the right. You can see it's a very nice correction of the forehead shape. Metopic synostosis, this one is really varied. So whereas we think of sutures closing at about 2 years of age on average, and technically it's actually not until the end of puberty. So the sutures don't technically fuse until all of your bones stop growing, which is at the end of puberty. So suture fusion really should be 16 or 18 years of age, but we stop using them by about 2 years of age. But the metopic suture can be closed at birth, or it can be closed by 3 months of age. In fact, 40% of babies have it closed by 3 months of age. So calling closure of the metopic synostosis is not always correct, because synostosis, the implication is it's abnormal. And if you just have the suture closed, that could be quite normal. So this is a case of clear metopic synostosis, and I'm saying that because the interfrontal angle is below the norm of about 118 degrees. In fact, the norm is 135 degrees. The threshold for calling it synostosis is 118. But this is just what we call a metopic ridge. It's a normal forehead shape. There's a little bit of ridge because that bone closed early, but it's going to go away over the next 3 to 5 years. So you don't want to operate on metopic ridges, but you do want to operate on what we call trigonocephaly, this triangular shaped forehead. And again, you could do that through a minimally invasive operation, through that small incision, or you could do it through a bigger operation where you take off all the bones and reshape them. Just to go a little bit through metopic, here you can see classic trigonocephaly, that pointiness up in the forehead. Here I've marked the fontanelle, marked the course of the suture, and marked where the incision should be at the hairline. This is now the same patient all draped out. Here you can see us infiltrating with lidocaine, making the incision, using the high-speed drill here to get through the bone, have a nice little burr hole here that we then enlarge, and then we use the endoscope to look down, and then use the same scissor to cut out the bone. And here's a look through the endoscope, right? So this is now the edge of the bone. So we've taken out the part in the middle, and this is the left frontal bone and the right frontal bone with the metopic suture now removed. And this is just closing it up at the end, giving a little irrigation, and that's what the incision looks like. It's behind the hairline, so it's really not a visible incision over time. And this is the correction we get, right? So this is, again, just the laser scans. That's right before surgery, and this is after surgery. So you can see you can get a nice forehead correction. And then lambdoid synostosis. True lambdoid synostosis is a very rare phenomenon. I operate on about 100 children a year for synostosis, and in any given year, I'll see maybe 1 or 2 lambdoid synostosis cases. So most kids who have flattening in the back of the head, as I said, it's sleep-related, not synostosis. All right, and we recently published our experience treating that endoscopically, and it works quite well. So can you use it if multiple sutures are closed? And the answer is yes. We would operate if up to 2 sutures are closed, we'd still do it endoscopically. As you start to get to 3 or 4 sutures, probably you're getting to that cloverleaf situation where the brain is eroding so much into the bone that the endoscope might not be safe. And here's a child with Apert syndrome. As I said, they get this sort of high, short head. We take out the bone, treat it. It all lengthens out over time. So this was an article that John Muir and I did, invited review for the 75th anniversary of the Journal of Neurosurgery, and just looking, where's the field heading? And I think where the field is heading is where we see it now, that, these are sorts of conditions we can approach in lots of different ways. So why don't we use endoscopic surgery? I mean, this has been on the website of a very well-known craniofacial surgeon now for nearly 20 years, talking about why we shouldn't use endoscopic surgery. And basically every one of the reasons is debunked. So I'll go through some of them here. That he says, well, correction is not achieved at surgery. So infants must wear a headband up to a year afterwards. And that's true, right? It's if you're going to treat him with a helmet afterwards, then you're going to treat them with a helmet. Most families would prefer that than to the big incisions and the blood transfusions, et cetera. And I put the mostly true because no one helmets for a year. You'll helmet perhaps up to your first birthday, so maybe 5 or 6 months, maybe 7 months. And like I said, should that be choice of the surgeon or the choice of the family? This is another statement made that the headbands are restrictive. They're similar to synostosis because they restrict head growth. I'd say that's unequivocally wrong. Helmets have been really well studied. There have been literally now hundreds of thousands of kids in helmets. And basically what they're doing is they're leaving gaps where you need new growth. They're not a vice. They're not pushing the head into new shapes. They're just allowing for growth into the flat areas. How about why helmets over like springs or distractors? Some of the reasons I like helmets over springs is because, one, you can change the shape in many different dimensions. Springs only work in one plane, so they're sort of two-dimensional. And the other is you can modify it over time. If it's not going exactly the way you want, you can change the helmet, change the shape. Finally, you don't need another operation. If you put in springs, you've got to take them out. So again, the helmets are really safe. They don't restrict growth. This has been well proven and well documented. And these are just various helmets that we see for different conditions. So the top child has bilateral coronal, the bottom right is sagittal, and the bottom left is metopic. How about, are these procedures not as effective? So this is a study I published 3 years ago, and we looked at 500 consecutive patients that I operated on. And I'd say these operations are very, very effective. I wouldn't do them if they weren't. They're not as much fun to do as big operations. They don't pay as well as big operations. We do it because it's the right thing for the child. So if I look at my first 500 patients, you can see this is an interesting phenomenon. About 2/3 of patients with synostosis are boys. And this is because sagittal synostosis, which is half of all synostosis, is 4-to-1 male to female. We don't really understand why, but it's 4-to-1. And age at surgery, you should see, is about 3 months, and that'll come up in a little bit. Estimated blood loss, overall pretty small. Transfusion rates are, you'll see on the coming up slide, is about 5 to 6%. This is just a breakdown of the patients we operated on. You can see 50% are sagittal, as I said, and 7% of them had syndromes. So that's we will operate in the setting of syndromes. Transfusion rate, you see there, 6%. Complication rate was about 1.4%. And then reoperation rates. How many of these kids went on to need more surgery? It was about 3.6%. And we'll compare that in just a moment to open operations. So what are the reoperation rates after open surgery? It's actually higher, right? So this is a really well-known group down in Washington, D.C. Their reoperation rates after open surgery was 5%. This is reoperation rates for syndromic synostosis, and going anywhere from about 25% up to 100%, depending on which syndrome you had. So when you have a child with synostosis, you have to be prepared for them to fuse sutures back together and need more surgery, regardless of the type of initial operation they had. This is the group from CHOP, basically showing a real degradation in outcomes over time. So when you do these big operations, you're taking the bones off, you're putting them in the position you want them to be in, which is great, but they don't then grow normally over time. And I think this is different from endoscopic surgery, and I'll go over that in a bit. But this is one of the top groups in the country, basically saying Whitaker class 3 or 4, those are poor outcomes, was about 38% of their group. How about reoperating because intracranial pressure developed? That's pretty common as well in synostosis. This is one group from Pittsburgh where they had about 1.5% of their kids developed elevated ICP. This is a group from Portland, 6.2% of their patients developed elevated intracranial pressure. This is just something else that surgeon said, well, you shouldn't do endoscopic surgery because the risk of holes in the head. No, it just doesn't happen. I've done 500 operations. Only 2 kids have had a hole in the head that I had to correct. I'm sorry that I've now done 800, but the article was 500. But skull defects they're well known after craniofacial surgery. Whenever you operate past 8 or 9 months of age, the skull doesn't regenerate the way it does in an infant. So it's skull defects are a known problem. How about, are these operations more dangerous? Some people still contend that the endoscopic operation is more dangerous because you have a restricted field of view. This is my first 100 cases, mean operating time 48 minutes. Mean blood loss 23 mLs, 8 transfusions, and that's in the first 100. Mean hospital stay 1 day. The long and short of it is these operations are much safer. It's like not even comparable. Transfusion rates from as high as 90 to 100% in open operations, and as low as really these days, my transfusion rates are about 2%. So a verdict, I'd say by all morphologic measurements, they're comparable. Like, you shouldn't choose open or endoscopic based on the outcome you want. They're both going to give you great outcomes, but endoscopic surgery is much safer and it's very well published. Like I said, it's now more published than open operations. How do you follow children after the surgery? Closely. So, if you're going to commit to doing these sorts of operations, you have to see the kids back. About every 1 to 2 months in the first year, and then once a year for the next 5 years. Why do I say for the next 5 years? So why do we follow the kids till they're about 6? Well, you have to understand the way the brain grows for that, right? So if you look at the brain weight over time, essentially it's reached 100% between 5 and 6 years of age, right? So we obviously all get smarter over time, but it's not because our brains are growing more. It's because they're sort of rewiring and maturing in other ways. But if you follow a child with synostosis till they're about 5 or 6, you'll have caught all the kids who are going to develop the elevated pressures. And this is just another more advanced study showing the same thing, greater than 95% complete by 6 years of age. So when you're following a child with synostosis, you got to follow them until they're at least 6. Most kids that are going to need more surgery will probably need it by 2 or 3 years of age. But if you don't follow them until they're 6, you're going to miss some kids. This is just an example of a child who was treated endoscopically, right? Here's bilateral coronal, opened up the coronal sutures. They look okay, but what happens over time? They close their sagittal suture, they close the metopic suture, and they started to close both coronal sutures. So kids with synostosis are just more likely to fuse their bones. I mentioned a little bit before what's called the neosuture. So why might endoscopic surgery actually be better than open surgery? So when you take off all the bones in a big open operation and you put them back with plates and things, you never develop the normal sutures again. So whatever bones you take off, you lose those sutures. But when you do these minimally invasive operations, this is the same child before and after surgery. You can see the eyes leveled out, the nose got straight. But even cooler is that they formed a completely normal new suture after I removed the fused one. So this was an article I published on that. But this has now been seen by multiple centers. So here you take out a fused sagittal suture and you get a normal sagittal suture. You take out a fused lambdoid suture, you get a normal lambdoid suture. Here's another case of apron. Take out 2 fused coronal sutures, you get 2 normal coronal sutures. Why is that so important? Because those are going to grow normally over time. And that's, to me, probably the primary advantage of this operation over the bigger one, is you get normal growth through the lifetime, which you often don't get after the bigger operations. How about the cost value? We're almost at the end here, so just hang on a few more slides. What do you think is a cheaper way to treat this? Not even close. So we looked at this and then multiple other centers have looked at it. and they all came to the same result, that treating a child endoscopically costs about 40% of what it costs to treat them in a big operation. And this is everything. This is including the helmets, including the gas mileage to get to your helmet appointments. You could look at everything, and it's still a far cheaper way to go. And as we're really looking, probably many of you are studying this a lot more than I did when I was a medical student, about the value of healthcare. So you want an outcome that's meaningful to the patient, and you want it at a cheap cost. So if that cost is low, the value is much, much higher. I would argue this is a far more valuable way of treating the condition. So in the appropriate setting, both types of surgery are effective. How do I decide how to do it? Well, if they're 3 to 4 months of age, I'm probably going to go endoscopic. If they're over 6 months, it's really not going to work, because the driver of the growth is the expansion of the brain. And by 6 months, it's already slowing down. Severity, there are some cases that are just too severe for endoscopic. They're rare, maybe a few cases a year that I see where I say, I can't do this because it's just too complex. Whereas the open operation you can do on anyone. Reoperation, endoscopic, because it's a time-limited operation. If you've done it and didn't work, your bailout's going to be the open operation later on. So you can't redo endoscopic operations with another endoscopic operation, and obviously family preference. So in conclusion, there's lots of literature that, like I said, first article came out in 1995. So nearly 30 years that show that the endoscopic surgery is safe, it's effective, and it's reliable. I'd say all of the theoretical concerns about the disadvantages are just not borne out by long-term experience. And the outcomes are really pretty equivalent between the open and endoscopic surgery. Endoscopic, far more value. And I'd say at this point in time, if you're going to go into craniofacial surgery, you really need to know how to do them both. And if you don't, number one, it's a disservice to the patients, and number two is they're going to go somewhere else, so you're just going to lose the patients. All right, just this is partial references that I published on the topic, and hope that was helpful, and happy to take any questions.
Thank you so much, Dr. Proctor. That was excellent. Feel free to throw your questions in the chat. But while we wait, I was just kind of curious about sort of the training for any kind of endoscopic procedure, in particular this one, what the learning curve was like for you, and that sort of, it seems like, as you mentioned, there's been a lot of resistance to transitioning from open to endoscopic, and what your experience has been with that as you have gone through the training.
Yeah, so when I was a trainee, I couldn't really train in endoscopic surgery, so it's a little bit self-taught. David Jimenez, who's a neurosurgeon down in Texas, he and Constance Baroni, who is a plastic surgeon, they developed a technique. So many of us sort of learned about it from them. I'd say most people going into neurosurgery now, this will be standard training. So anything, any field you go into in neurosurgery these days, you're going to learn how to use an endoscope, which is different from when I was training. So it might be for tumor removal. It might be for treatment of hydrocephalus. It might be for some spine operations, or it may be for synostosis. But the learning curve should not be nearly as steep, because it'll just be a basic part of your training.
Absolutely. We do have a question. Why and how is unilateral hearing loss caused in hydrocephalus? That might have been.
I'm not sure I know the answer to that question. It's certainly a non-synostosis question.
Maybe they meant, I'm not exactly sure.
So you can see hearing loss in certain synostosis conditions. There's things like Muncke syndrome or Sethra-Joudson that are inherent features of which are hearing loss. In hydrocephalus, I really don't know if that is the true question. I'm not sure why you'd have unilateral hearing loss. Next
Next
question.
question here. Trying to put that on the screen. How long does an open procedure for craniosynostosis, normally take compared to the about 30 minutes for the endoscopic?
Right. So I mentioned that today I did 2 operations. One was minimally invasive and one was open. So the minimally invasive one I did in one room starting at 7:30 while the anesthesiologists were putting the other patient to sleep and putting in the line. So I was done with the first patient. The endoscopic surgery indeed took like 30 minutes. They were out of the room by about 9:15 in the morning. The operation, actually the skin incision on the second operation was made at about 9:30. It was made by the plastics surgeon. So that both patients went in the room at 7:30 this morning. One was out at 9:15 and the other was out at 3 in the afternoon. So just to give you a sense. So the open operations are roughly 4 hours, and that's by a pretty experienced team. And that's skin to skin time, right? Not the entire surgical time.
Thank you. And then one other question. Do we have an idea of what is the cause for early suture fusion?
Yeah, great question. We have lots of ideas, right? So we now can find the gene for about 1 in every 5 cases of synostosis. So for, let's say, Apert and Cruzon, which I've been talking about a fair bit, we know the genes for both of them. It's both FGFR receptors. One is FGFR2, the other is FGFR3. We know lots of other genes, the twist gene and other genes that cause synostosis. Still to this day, there's lots of cases of synostosis where our genetic capability is not strong enough to fully discern. But we know that even a child that we call sporadic synostosis, so that their sutures fused, but no one else in the family has it, their child has a 1 in 20 chance of having synostosis. So these are they're not random occurrences. We just can't always find the gene. So I would say, in my view, all cases of synostosis have a genetic cause, and we're just not yet smart enough to know what it is.
Yeah. And I imagine it's, as you mentioned, with animal models being difficult to establish for this condition, it's also difficult to further study how you might manipulate gene expression to help treat the condition.
Yeah, exactly. I mean, you can manipulate the genes, and there's certain fish models even, which is funny to think of fish having synostosis, but it's there are very few, outside of a couple of breeds of dogs, very few models of naturally occurring synostosis.
I had one last question about, I recently came across a study that was kind of looking at overall for craniosynostosis, not specifically looking at endoscopic versus open, but they looked at long-term outcomes and found some differences in working memory in a long ways down the road from these initial procedures. Are you aware of any studies that are starting to compare this long-term sort of intellectual or neuropsych outcomes?
Yeah, so that's really a great question. We are similar to genetics. We understand a lot less about this than we want to, and then we will in the future. Definitely, if you look at big cohorts of kids with synostosis and without synostosis, and if you think the IQ normalizes to 100, right? That any population should normalize their IQ to 100. Kids with synostosis, it tends to be 1 to 2 points lower. So if you look at big cohorts, the average IQ is about 98 to 99. So there's definitely a little bit of a shift. The vast majority of kids with synostosis are fine, and probably would be fine even if you didn't do surgery. But some of them are not fine, and we're really just starting to learn more about what impacts that. Is it doing an earlier operation helps because, well, you're releasing the brain earlier? Is it doing an early operation doesn't help because you're exposing the brain to anesthesia earlier? Is doing a shorter operation better because they're exposing a baby to less anesthesia? So these are all things we're still trying to work out the best paradigm. The only really big study ever done looking at intellectual outcome in synostosis found a breakpoint of 1 year. So it's like kids who were operated on before a year seem to do better than after a year, but it's the study is like 40 years old now, and it's really not relevant to modern surgical techniques. So it's pretty clear though that if you let a child develop elevated pressures and then don't operate until then, that's going to be somehow detrimental.
Absolutely. Okay, looks like we have maybe time for one last question here. Can the endoscopic be done to a 7-month-old baby? So if you're out of that, 6-month window, are there any situations where you might consider doing endoscopic anyway?
Yeah, so it's a really good question. So if you think of the growth curve I showed you, you're past the peak of the growth curve, so you're not going to get as much push of the brain. If you decided you'd use something like springs, well, the springs are going to do some of that pushing for you, so you can push the envelope a little bit more. I would say the oldest kids I've ever operated on are really right in that 6 to 7 month range. But I will say that I was recently at a meeting with David Jimenez, and he's going to be publishing soon a series where they've been doing this surgery up to 9 months of age, and he said that the results were pretty good. I haven't seen it, but he's one of the most experienced endoscopic synostosis surgeons there is, and he says he's pushing the envelope out. So I'd say theoretically you can, although there's no doubt in our series, the kids that were closer to 3 months had better results than the kids that were done older.
Interesting. We'll have to keep an eye out for that study. All right. If there are no more questions in the chat, then I think we can go ahead and close things out. Oh, wait, one more question. Are there any other sequelae that have been identified with craniosynostosis procedures?
It's a pretty broad question, so I'm not sure exactly how to answer it. I could, obviously, I said a lot in only 45 minutes. I could talk for days on synostosis. It's really the majority of what I do. I mean, there are lots of other sequelae, and there's some of these syndromes have lots of other systemic abnormalities, fusions of elbows, hands, feet. So I'd sort of need a little bit more specificity on the question, but there's a lot. Synostosis in neurosurgery, we've tended to think, well, if you could take out a brain tumor, you know how to work with the skull, and synostosis is nothing. But the reality is it's a far more complex subject than people have given it credit for.
Okay, well, I think with that, we can let people get back to their evenings. Thank you so much, Dr. Proctor, for your time and your expertise. That was an excellent talk. Really hit on a lot of really salient points, and got to cover more of the endoscopic side of things, which really nicely rounded out our series here. So thank you again so much for your time. And thank you to everybody that tuned in. This recording will be available on our video library, as I mentioned earlier. And please tune in on Saturday for our Women in Neurosurgery Weekend webinar.
Great. Well, kudos to you for doing this.
Thank you. Have a good night, everyone.